Hello, everybody. I know we're just waiting for people to log in. We've just opened up the chat. But if you can please introduce yourself, say your name and the organization where you're from, we would greatly look forward to sort of meeting you. And we'll just give everybody a couple of minutes to come in, and then I'll start us off in about 3 minutes. All right, I'll just give it another minute and then we'll kick off. Thank you to everybody who's attending today. Okay, great. So thank you all. My name is Amnesty Lefevre. I'll be today's chair of this webinar. Our webinar today is on digital tools and engagement approaches to promote sexual and reproductive healthcare services. This is part of the WeMove Adolescent Health webinar series hosted by the Desmond Tutu Health Foundation and IAVI. I'm an associate professor in the School of Public Health at the University of Cape Town, and we thank you all for joining us today. We're really looking forward to an interesting and interactive session. Today, we present to you the 6th webinar in the 3rd WeMove series, and we'll hear talks first from Professor Kathryn Muessig, then Cristianne Wendler, and Kistenmacher, and in between we'll have an artistic interlude from Dshamilja Roshani. This will be followed by a panel discuss Niwagaba. The topics are first, strategies for optimizing end user engagement with digital health interventions. Then from Shout Out Tech, utilizing human-centered technology to improve health prevention program implementation for youth in South Africa. And then from Young Africa Live, digital media for sexual health outcomes. To start off, we'd like to know a little bit more about each of you and what you think. And so to kick us off, we'll have a quick poll. And can I ask our colleagues to please, so if you can see here, the question is on social media, what social media brings with regard to benefit and risks. So the question says, which of the following risks is often reported by adolescents in your community? So we know multiple answers are possible, but again, just tell us the leading risk that you think adolescents in your community face. Great. So we'll just wait for some of those answers to come in. And then we'll later on do a second poll question. So I'm seeing low participation rates. So we promise we won't kick you out of the webinar if you don't participate, but we'd love it if you'd try and answer some of these questions.
Sorry, Amnesty, could I just?
Yeah, come tell me. Cristianne, over to you. We've lost you, Cristianne. Did you? Hello? Yeah. Okay. So while we're waiting for Cristianne to come back with any questions, you can see some of the answers are just coming in. So far, physical violence is the risk that's most often reported by adolescents in their community. Great. And again, just to clarify, this would be risks related to social media potential social media use. So again, falling under harms related to social media use for adolescents in your community. So great. I think, so of these, yeah, just great. I think we're just a couple seconds here to let the final one come in. And it still looks like physical violence sort of has won out. So feel free to kind of put comments in the question and answers or share your thoughts on this. Great. All right. So I think this is something hopefully we can pick up on as our conversation today continues. I want to hand us over to our first speaker, Dr. Kathryn Muessig. She uses she, her pronouns, is a professor and associate director of the Institute on Digital Health and Innovation at Florida State University. Dr. Muessig is a behavioral scientist who develops and evaluates interventions that combine digital health solutions with behavior change strategies and health systems navigation with the broader aim of decreasing HIV transmission and improving healthcare for people living with HIV. We're very pleased to welcome her today as our keynote speaker. She'll be speaking on strategies for optimizing end user engagement with digital health interventions. Over to you, Kate.
Thank you. Can you hear me okay?
Yeah, you're great.
Great. And is the PowerPoint in presentation mode?
Yes.
Yes.
Thank you. Great. Well, I'm excited to present today, and thank you everyone for joining us, whatever time of day it is where you are. As Amnesty mentioned, my name is Kate Muessig, she, her pronouns. I am a professor and the associate director of the Institute on Innovation at Florida State University. It doesn't seem to want to let me advance. Okay. Are you advancing it for me or am I doing it? I think you
I'm
guys
not
are.
personally. I'm
I will do it. It's okay.
okay.
Hang on. I'd like to share it from my screen if that's possible.
That's fine.
Okay, thank you. Great, sorry about that. All right, well, I just want to acknowledge all our collaborators and partners and for supporting the work that's presented here, as well as the seminar today. As I mentioned, I'm the Associate Director of the Institute on Digital Health and Innovation, and our mission is threefold on research, training, and innovation. We are a multidisciplinary group, and we have a large focus on HIV prevention and care, but are not limited to that in terms of digital health initiatives. I also just wanted to acknowledge quickly our staff. There's a very large group of faculty and staff that have contributed to the work that I present today, and it would not be possible without them. So I have three quick topics to go through. The first one is to talk about what engagement is in digital health interventions and why it matters. The second one is to focus on some foundational elements of designing digital health interventions to optimize engagement, and then a few strategies to leave you with for enhancing and sustaining throughout the implementation of your digital health initiatives or interventions. A lot of the examples that I'll present today or use as illustrations come from the Health Empowerment Platform. This is a theory-based status-neutral digital health platform that our lab has designed and iterated over the past 12 years. It has been identified by the US CDC as an evidence-based intervention for HIV risk reduction. It has numerous different features from educational to interactional, goal-setting activities, social support, an Ask the Expert health question and answer platform, medication and health behavior tracking, as well as abilities to order medical test kits, and have two-way secure communication. This platform is currently being used by our lab and by partner labs across the world, and currently in studies in 8 different countries, a number of studies in the US, but also in sub-Saharan Africa as well, and not limited to HIV work, but expanding into mental health and stigma reduction. One of the most exciting uses of and adaptations of the platform is the USAID supported VUCA Plus study, which is part of the Engage interventions. It's a smartphone intervention app that's tailored to support medication adherence and persistence for adolescent girls and young women in South Africa. And it's being tested in a randomized control trial led by our DTHF partners in South Africa. This adaptation was led by Conrad and EVMS using a human-centered design prep campaign that they created with South African women. These are some of the images, as you can see, really meant to be empowering and attractive for young women. And it's one adaptation and advancement of the HMP platform. So there are a lot of examples I'll share from VUCA Plus as well. So what is engagement and why does it matter? There are 2 conceptual foundations for engagement. At its heart, this is the extent of a person's use of an intervention and its features. And it's also a subjective experience characterized by attention, interest, and psychological and emotional affect. When we measure end user engagement in interventions, we think about diverse ways to measure. So this might look like the amount of content or modules or activities that someone completes. You can look at the frequency, how often they use your platform, your intervention, how often they track medications, if that's the focus of it. You can look at the frequency, what are the most common days or times of days, duration, total time spent, or looking at how time spent changes over the course of your intervention, if it's a 3-week or 3-month or 3-year, looking at how people evolve their use over time. And then the depth of their engagement. So how much of what you have presented to them do they consume? How involved are their contributions if it's a forum or social support? And how does that way that they use your intervention or platform change over time? Engagement does matter, and I would argue is perhaps the single most important aspect of the success of digital health interventions. If they don't use your product, then you won't know whether it worked or not. And if it is something that would work, if they don't use it, then it won't have an impact on them. We know that there's a lot of churn and turnover in the use of apps and the use of other digital products and platforms. And in many digital health intervention trials that have been published, you'll see a lot of drop-off in users or in the way that they use the tools over time. Incorporating focused engagement strategies can support the acceptability, usability, and adherence, and most importantly, the impact. So engagement, although there are not a lot of studies that measure the impact of engagement on outcomes well, there's been a recent systematic review that it just came out, Choi et al. And current HIV/AIDS reports linked at the bottom here. And this systematic review found that among studies that do look at the association of use and HIV-related outcomes, the ones that do measure it, the majority found a positive relationship with primary or secondary outcomes. In our own work, we have found this to be the case. So in the Health Empowerment Platform, the original statewide trial that was done among Black, gay, and bisexual men and transgender women, we did find a significantly stronger intervention effect among participants who used the intervention for more than 60 minutes over the course of the intervention period. So almost 4 times the effect size when we did that sub-analysis. So how can we optimize engagement? It starts from the beginning when you are designing your platform, and it has to be incorporated throughout the process. Things like centering your end users throughout the process from the very beginning through iterating and evaluating. We use tailoring and personalization a lot to make sure the content is relevant, including push factors. Much of the research out there, particularly around SMS or messaging interventions, has shown that bidirectional or interactive components are more effective. And then providing opportunities for self-monitoring and goal setting and feedback, fostering interactivity and social support within the context of your product, and including game-based elements and making things fun and rewarding for people. When we're tailoring, we think about tailoring across a number of different aspects of the intervention. So this is anything that will make your platform or product more salient and relevant and engaging to your end user. That might be in terms of the content, that might be in terms of the framing, who delivers it, the voice of the person that it's written in, as well as the different channels that you could choose to deliver that content digitally. One of the strongest tools that we have when we're using digital health interventions is the ability to tailor and retailor over time. So you can tailor at the start based on your prior knowledge, based on your formative research, but then you can continue to tailor as your intervention plays out through the self-reported needs of your end user population and their interests. And you can look at what they do end up using and engaging with, and continue to evaluate and tailor and refine the content that you provide them based on their self-evaluations. With self-monitoring, goal setting, and feedback, tracking, as we know, serves as a reminder and a cue to action. So if you're tracking medication, that daily reminder, and then working with end users in the way you design the intervention to help them set goals and then see their progress toward those goals. If we think about a lot of the fitness apps and tools that are out there, the ability to see your own self-progress and tracking over time, your own record, really elevates the ability for behavior change and for greater engagement. When people see themselves succeeding or improving in something, they are more likely to continue engaging with that tool. And then monitoring in real time can also be used, again, for that continued adaptation of your platform. So if you can show someone the patterns in the way that they are taking their medication, you can help them adjust, and you can adjust the intervention itself to better support their needs. Social support, if we think about the most common uses of digital tools out there in the world, we know that social media and social platforms are one of the most sticky or engaging. There are a lot of interventions coming out now that are using existing online social networking platforms, Facebook, WhatsApp in particular, in sub-Saharan Africa, a number of HIV prevention and care interventions that are showing promise for high levels of user retention and engagement in using WhatsApp. And then using digital health intervention support networks can really help us bypass some of the geographic and time limited barriers to engagement with interventions. And then the anonymity that's offered really helps overcoming stigma and social isolation. So again, in our own work, we have found this to be the case in the initial health empowerment platform that had a strong social support and forum component. When we did a content analysis of the types of posts that people contributed to the forum, so almost 1,500 posts, we found that those related to sexuality and HIV-related stigma were over half of the posts had that kind of content. And then when we looked at what people were saying related to stigma, we found that the majority of posts were actually challenging or resisting, demonstrating resilience against stigma. So this intervention had an impact on the way that people advanced, the way they thought about stigma, and the way that they pushed back against it. The intervention was then expanded in a nationwide trial in the US, and that trial and analysis is still ongoing. But in an early analysis among the first 348 participants who were in the intervention arm, we did a comparison between those who were observers in the forum, so passive readers or those who didn't interact at all, and those who contributed to the forum, and saw a significant change in measures, self-reported measures of everyday discrimination and enacted stigma. So showing promise, and this was among gay and bisexual men and transgender women who identified as Black and Latinx in the US. Lastly, including game-based elements for fun. There are a lot of different ways we can do this. We know that interventions that use gamification can deliver highly engaging content and enhance the degree and the depth of the way participants will or patients will interact with your intervention and support increased behavior change. So a few strategies for what you can do to enhance and sustain engagement throughout your implementation process. So now you've designed your intervention or your platform, it's out there in the field, whether it's in the context of a research study or an implementation project. We have found that you can roughly group people into 3 buckets. You'll have people who are highly engaged, and that's going to be about 1/3 to 1/4 of your population. That's your design success, and you want to keep that streak going and support those people and do more of what's keeping them engaged. You'll have about 1/4 to 1/3 of people who are your low engagers, and they may be having technical problems or connectivity issues. They may not have understood what the point was. They may just be a mismatch, and this digital health intervention is not right for them. So those folks you can support with human interaction, staff outreach, additional technical support to try to see, can you get more of those folks into your high or moderate engagement group. And then the majority of your population is going to be in that moderate or inconsistent engagement group. They might start off strong and then taper and fade over time, or they may come in and out. They may use it as less frequently than you want. So first you want to check through, are they having problems related to low engagement, technical issues? Once you've gone through that list, then looking at their engagement patterns. What are they using? When are they using? And can you use nudges or motivations or other rewards to keep them at least moderately engaged or nudge them toward that high engagement group? The 3 quick buckets for how to do this, I'm going to call them fun, fresh, and fabulous, trends and influencers, and in it to win it. Fun, fresh, and fabulous. If you think about this is, you have to keep everything new and interesting. If we think about the way people use these tools in their daily lives, it's to interact with the newest, the most popular content that's out there. So keeping things fun, using end user polls, interactive elements, sharing back information to your participants, having a planned content release calendar so that you are releasing content that's relevant to the holiday that's coming up or the current event that's happened, keeping a news feed that expands beyond your particular health topic to keep people coming back and interested. Trends and influencers. You've got
4 minutes.
Thank you.
Sorry.
Trends and influence. Yep. With your trends and influencers, again, thinking about how people typically use social media, you can look at what is the most commonly viewed content. For example, in the VUCA study, we've seen that although the focus is on PrEP, the content that women are reading is related to reproductive health, to sexual relationships and healthy relationships, to mental health. So we know that this content is popular. We're going to create more of this content. It's valuable to folks. They're reading it. It's keeping them coming back. So we're adjusting as we go. And then thinking about even what day of the week, what time of day are people most likely using your intervention? If you're focusing on young girls and women, they're in school during the day, so it doesn't make sense to release new content or to try to engage with them during that time of day. Evenings or weekends might be better. And then thinking about creative ways to use your influencers. Look at who your high users are and what they're doing, and how can you utilize that either in the context of your intervention or beyond it. So we often look at our super users and we might invite them to become peer influencers or advisory board members after they've completed the intervention. They clearly have a vested interest, and you've done something that resonated with them. So you want to keep them on your team in some way. You can also build on forum topics or other topics that you find to be engaging, whether that happens in your intervention or beyond it, that generate the most engaging conversations. Replicate that over time, encourage that so that you keep people coming back. And then in it to win it. This builds on the gamification piece. People love a contest. People love when you have a time-limited competition that they can contribute to, a challenge or a fun puzzle to solve. Again, think of your own behavior on digital health platforms, the games that you play, the things that you continue to come back to. Keeping it fresh, connecting people's engagement with their ability to unlock new features or new items over time, and then providing rewards, whether those are virtual rewards or real rewards, things that translate to actual items or actual money in the real world. These are all highly engaging elements that you can incorporate into your work. So to close out, just to summarize, I think fundamentals of engagement in digital health interventions to keep in mind. We need to keep novelty at the front. People want new experiences and content. They need a challenge, and that increases their engagement and is rewarding and keeps them coming back. Creating social meaning, whether that's through their interactions or through the value that they gain from interacting with your digital health intervention or platform, and then making sure it's fun. If it's not fun, they won't come back, they won't use it. It has to be fun and easy to use, and that experience will reinforce their use and keep them coming back. So with that, I will close and again acknowledge our funders and leaders and partners in all of this work. And thank you for the opportunity to speak today.
Thank you so much, Kate, for that really thoughtful and insightful presentation. We're going to hold questions until after our other speakers have come. But if you have any burning sort of clarifications or thoughts, please do use the Q&A function. And if you've not already introduced yourself in the webinar chat, please do so there. And without further ado, I'd like to introduce our next speaker. She is an artist. Dshamilja Roshani is a Berlin-born poet, writer, and spoken word artist and performer of German and Iranian descent, who now lives here in South Africa. Over to you.
Hello, my name is Dshamilja Roshani. My pronouns are they, them. I'm a poet, writer, and performer based in Johannesburg. And it is my pleasure to once again share my work with this platform. Please feel free to reach out if you're interested. You can find me on all social media platforms as Dshamilja Roshani. You can also email me, dshamilja.roshani@gmail.com. Right, so the piece I've prepared for today is titled Closer Than You Think. Imagine a lake of knowledge, a lake made just for you, sitting calmly in the palm of your hands, its insides as deep as intentions clean. You dive into it with ease by dipping your fingertips into the still surface of its screen. Imagine a lake of knowledge, a lake in the exact shape of your thirst. It holds space for all of your questions. Tailored advice appears from its depth. Gone are the days when you had to drag your bones far and waste your time in crowded clinics. For the lake ripples into the face of a doctor, right here, where you are, watering your health with whatever you need. Imagine a lake of knowledge, a lake that speaks back to your fears, away from a world muddied by shame. You bend over its water and see yourself clearly. The parts of your body you are shy to reveal, the parts between your legs that people call dirty. The lake helps you to make sense of it all and tends to your body whenever you seek it. Imagine a lake of knowledge, a lake that does not ask you to hide. In a world so parched of deviant colors, where rainbows are chased into disappearance, the lake allows you to dive into yourself. Here you find others who are alike, imbued with colors, fluid like you. Imagine this lake. Imagine its view. Then make your way to the shore and download its nourishing blue.
Wonderful. Thank you so much to Dshamilja Roshani for that beautiful poem. I'd like to now introduce our second speaker, is a public health and development innovator. She focuses on HIV, gender-based violence, sexual reproductive health, services for youth. She's very passionate about human-centered design technology and its capacity to drive impact. The title of her talk is Shout Tech, Utilizing Human-Centered Technology to Improve HIV Prevention Programs, Program Implementation for Youth in South Africa. Without further ado, over to you.
My name is Cristianne Wendler, and I'm the Technical Director at Shout It Now. Here today to talk to you about our tech and how we use human-centered design to empower and reach young people in South Africa. But before we talk digital tools, let's talk people. Because no matter how high the function, no matter how great the user interface, a digital tool does not matter without people. So for us, our people are young people in South Africa. We need to understand their environment, their aspirations, their fears. All of these things matter for how a digital tool ultimately will reach them and be perceived, as well as just be able to be accessed. So really understanding our population is absolutely the first step before we even talk about a digital tool. To do that, we employ human-centered design across all of our program implementation. So the first element there is focusing on the population. And this is a continual process that we're always wanting to learn from and listen to the population we serve. The second is that context matters. This is context for the environment in which the young people live, the context for how they're able to access technology. For instance, in South Africa, we have load shedding on an almost daily basis, which impacts connectivity. Data access is a real barrier. Many young people have access to a smartphone, but not necessarily data. And then the third element is understanding this is complex. Not only the issues and how they interplay in a young person's life, such as GBV, HIV, these are complex issues, but also the complexity not only in the tool itself. Sometimes in creating it, we need to be able to design that complexity. It runs on the back end, but how do we make sure that we're factoring in that complexity correctly and catering for it? But very clearly on number 4 there, what problem are we trying to solve? So amongst that complexity, we have to be able to be clear of purpose of why we're creating a tool and what our hoped and intended outcome is to be. And then number 5 is everything is connected. So no digital tool should be created in isolation or as a silo. It needs to be embedded programmatically so that young people have options to connect in virtually as well as through a person or both. And they have a seamless client experience regardless of which avenue they choose. And then the 6th is that there must be continual learning and refinement. So at no point should a digital tool be considered done and dusted. We should always be learning from the users, getting feedback, and then refining and enhancing to drive greater impact. So on that second variable then, let's talk context for a moment. We predominantly serve adolescent girls and young women. I'm not going to read each of the stats on this slide, but this is the context in which they live. This is the problems we are out to solve. But these are very complex. So how do we make sure that as we design digital tools for a population that lives in this context and is facing this reality of HIV, gender-based violence, teen pregnancy, how do we make sure that our tool has impact within this context? So who are we as Shout It Now? We are a local South African organization that believes in a world where youth are empowered to make the best choices for their own health and well-being. And as we do that, I like to say that we aim for the trifecta. We want to bring together knowledge, empowerment, and access at every touch point that we have with a young person. And I say this because each of these three things matter for ultimate outcome. We can pour all kinds of great HIV prevention information into young people, but if they do not own that information, they do not understand it, they are not empowered by it, what's the point? Same with access. If we do not bring the services to the young people, we've given them the knowledge of how to prevent HIV or how to connect to gender-based violence services. But if that access isn't there, what's the point? So we really want to always, in our human-centered design, be able to bring these three elements together programmatically as well as in our digital tools. So how do we do that? We run a range of different services and functions. So we are best known for our mobile clinics up in the upper left. We are bright, we are loud, we are intentionally youthful looking and non-clinical so that young people feel welcome and accepted in our spaces. We are completely paperless. We run everything through an electronic client management system. We have a call center that connects in, we have apps, but all of these services, all of our programs are connected in regardless of which interface point, which entry point you come into our services, you will have that same feel, and we want you to have options across any of those service delivery platforms. So in terms of the services we provide both PrEP and PEP for HIV prevention. We have HIV testing with linkage to care if testing positive, contraception for male and female, life skills programs which are run in a range of settings both in community and schools, STI screening, gender-based violence prevention and post-violence care, as well as economic strengthening. With a youth unemployment rate between 50 to 60% in South Africa, any organization working with youth needs to be looking at this situation. How can we drive greater impact for young people in the economic space? So how does this all come together in terms of the technology? So Shout Tech is our interconnected system. So remember that element where we talked about everything has to be connected. Each of our pieces of tech connect in and speak to each other. So you can see at the top there in orange, Chomi and iShout. These are both client-led tools. An individual can explore information on their own terms, self-navigate, but if they choose to connect into services, they will be routed into the system and a human will get in touch with them. Then we have at the center there, Smart 2.0, that is the client management system that runs on all of our mobile clinics. But the minute, for instance, an individual would initiate on PrEP on our mobile clinic, they immediately are linked to Snowy2, which is our follow-up and retention system. So then our Connect Hub agents, that's what we call our call center, they would immediately receive that referral, follow up with the individual, and let them know that we see you've initiated on PrEP, we're here for you if you have any questions, and we're going to follow up with you in a month's time to get you scheduled for your follow-up appointment. And then on the other side, you have ShoutLink, and this is a service provider app, and this is used both with InShout as well as with partners, and this allows us to track seamlessly client journey across any number of services as well as service providers. And I think that's key in going back to everything has to be connected. That's beyond our organization as well. If we are going to comprehensively serve young people and address these complex issues, we have to collaborate with other partners. So both of our tools, Snowy2 and ShoutLink, are designed to work with other partners and be able to drive bidirectional referral. So delving into these a little bit more, if we look at our client-led digital tools, this is iShout and Shomi. iShout is our data-free mobile app for adolescent girls and young women. It's filled with youth-relevant features such as FAQs, service locators, as well as things like economic strengthening resources, such as how to create a CV. And the key here is that it's data free. Again, a really important contextual factor for the population we serve. Chomi is our multilingual gender-based violence chatbot available on WhatsApp. It's in 4 languages, and it allows a survivor to anonymously explore options and information. Now again, looking at human-centered design, when we designed Chomi, we were very clear on the problem we wanted to solve. We know that many survivors never come forward for the mental and physical health services that they need because of fear, because of the unknown, because of being judged by the service provider. Who's going to find out? And so we wanted to create a tool that put information and option in the hands of the people who need it, anonymously and on their own terms. If they want to connect into support services, they absolutely can, but the first and foremost is empowerment through information. So then as we shift to our service provider-led tools, the 3 here, Smart 2, Snowy 2, and ShoutLink, these again all work together. Smart 2.0 is that centralizing electronic client management system that tracks all services across all of our mobile clinics. Snowy 2 is our follow-up and scheduling system, and the main purpose of what that tool is designed for is client retention engagement. That's great if we have these beautiful mobile clinics that get people into services, but we have to make sure that we're able to retain and continue to engage clients as they need. So Snowy 2, very fit for purpose digital tool to drive that continued engagement. ShoutLink is our service provider app that allows us to track that seamless service delivery, whether it's within our services or within our partner services. And this is really important of being able to track an individual across multiple service providers to really drive that kind of collaboration. So as we look at impact, I'm not going to go through each of the numbers here, but we track it on a regular basis. Is our technology being used? What impact is it having? And how are we continuing to optimize? So you can see there on Snowy 2, we're tracking over about 7,000 engagements a month. On ShoutLink, we've got over 4,400 active users on that data-free app. And in Chomi, we've got almost 1,800 people who have accessed GBV information, with about a 39% success rate of those, 39% of those individuals requesting to be connected to support services. So in conclusion, digital tools need human-centered design. They need to be embedded within health programs, not as standalone interventions. And when created and deployed properly, digital tools create empowering spaces to help young people make informed decisions for their own health and well-being. Thank you for your time and the opportunity to present today.
Wonderful. Thank you so much, Cristianne. So before I introduce our 2 panelists, I'm going to ask the first 2 speakers just a quick sort of question each. So Kate, I wondered if you could just reflect on any advice that you might have for our audience with regard to measuring engagement, both through perhaps self-reported means and then through use of system-generated data. If you could just reflect on some of the challenges you might have faced, advice you might have for the folks thinking about design going forward. Over to you.
It's a great question. It's a big undertaking. I think one of the things that we have learned most over the years is that you have to think about measurement up front when you're designing the tool. There are ways to use existing analytics, like Google Analytics, other tools that you don't have to build yourself or input, but that does limit your ability to drill down somewhat to the individual level. But thinking about what you want to measure up front, what is meaningful, how do you want people to engage with your platform, your content, your intervention, and then really articulating what those measurements would be. And if you're working with a tech partner, working with them up front to make sure that they're collecting that information and then able to give it to you in a way that's meaningful. We've sometimes gotten files that are hundreds of thousands of data points that is not useful, and there's nothing you can do with it really. You'll need a statistician and a computer programmer to make sense of it. Or you think you are measuring something and it turns out you didn't have a a timestamp on any of it. So you have no idea if the person put their phone down and walked away an hour later. So those are, I think, really thinking about it up front and testing it out is the biggest thing that we've learned.
So I'm just seeing some hands raised from our colleagues at Desmond Tutu. Over to you guys.
Sorry, Chair. We just want you to check your message and then, sorry. Great. Great.
Oh gosh, okay. My apologies, guys. Apologies, I missed one additional presentation, so I've already failed at my job miserably. So I'll come back with additional questions. Sorry, Anne, I promise I didn't forget you. We're coming now. So this is our third speaker. Again, sincere apologies about that. Anne is a product strategist working on the triage of monitoring, working at the sort of triage of monitoring, evaluation, research, and learning, data science, so machine learning, and the user experience strategy, with a strong interest in improving healthcare impact and outcomes. She is a psychology PhD candidate focusing on behavioral modification with the aid of digital platforms. The title of her talk is Young Africa Live, Digital Media for Sexual Health Outcomes. Apologies, Anne, we've saved the best for last. Over to you.
No worries. Thank you. And I'm representing Reach Digital Health, and I'd like to introduce Young Africa Live to you, which is a sexual reproductive health intervention, which we've built in conjunction with the Elton John Foundation and BeWise, and they've enabled us to test a lot of things which we were interested in, amongst other things, an assumption that we had before we started building Young Africa Live, which was that education and knowledge is great, and it's absolutely necessary, but it's not the be-all and end-all in achieving clinical outcomes and changing behavior. We believe that adopting and maintaining healthy sexual behaviors involves an interplay of a lot of different factors, including sexual health literacy, but also things like individual beliefs, attitudes, values, cultural norms, interpersonal relationships, external influences, and access to resources, very important in Africa. So what we did was we had a look at what do we have to do in order to include other factors like that, which obviously involves that you have to deliver interventions in a personalized format and get to know your user before you start speaking to them. We used a measure in this called persistence because it in large speaks to different behaviors and can measure the extent to which different behaviors influence clinical outcomes, and started testing a whole array of these things so that we would know which user battles with which behavioral impediments. So we knew that users can't be treated as averages, and most of all, we also knew that if we didn't personalize interventions, a user spends around 2.3 days on the app on average, like on the platform, which wasn't what we wanted at all. So we started working with a concept which we called the Reach Risk Engine, which in large aims at allocating risk to certain health determinants, amongst other things, your behavioral barriers, in order to be able to correlate social demographics with social behavior, with behavioral outcomes and clinical outcomes, in order for us to be able to not only personalize interventions, but also prioritize interventions. So knowing how high your risk is in a particular behavioral domain would give us more insights as to what the first intervention would be that you would need and have to circumvent in order to be able to achieve the clinical outcomes. So knowing that to safeguard against illness and prevent disease, it's imperative to adhere to a regimen of healthy behaviors. We wanted to really make a point and prove that you have to move beyond education and that knowledge isn't enough. Young Africa Live thankfully gave us that opportunity, and we had a look at 300 Young Africa Live users in a survey looking at things like sexual health literacy versus the behavior within that domain. And this is probably not going to come as a surprise to you. We were all very young at one stage. And things like knowledge, as in knowing that condoms prevent STDs, is very, very high. It's 97% in those 300 users. But the actual translation of it, as in using a condom in the last sexual encounter, was very low, 56%. Those are not the only behaviors. You're welcome to look at the details of this. Very interesting findings, but it supported us in our assumption to tailor interventions and really look at different behaviors impeding the clinical outcome. So that meant looking at things like religion, culture, and also like social responsibility factors that play a role. In other words, like if you have a case of, hey, real men don't use condoms, what do you do? So working on different things like gender and age and culture as health determinants, including religion, enabled us to prioritize specific impediments and that in turn enabled us to enhance the probability of reducing risks and achieving optimal clinical outcomes. We mapped this again in the survey that we did, looking at the particular barriers that we should be working with. The reason why we applied them in the first place is because we found them in a lot of studies and existing literature reviews. So we knew that these behavioral barriers were problems in that particular health domain. And all we did was measure them before and after an intervention and have a look at whether they really are crucial in that domain. So, and this is also not a big surprise, looking at the amount of gender violence that we have in South Africa and the whole of Africa, we realized that 97% of the 300 people that we were working with had low gender attitude scores, which I find very scary. 60% scored as depressed and anxious. So we know, and I mean that we also knew at the outset that we did have a problem with mental health in general. We have low self-perceived health scores, insufficient social connectedness, in other words, insufficient social support, low body image scores, low self-esteem, mostly externalized locus of control, and extremely low resilience in the face of setbacks. So if you look at this in terms of a behavioral, psychological context, you know that the amount of empowerment or the decision-making ability of these users is extremely low in the face of sexual reproductive health. So what we did was include these barriers, measure them, and then map the change from before and after in persistence against clinical outcomes. We realized that by doing that and by mapping more and more users in regards to that and achieving things like that, I can say no to sex without a condom, significantly changed, and we could continue devising different strategies for different user clusters depending on these results that we achieved. In that survey, on the 300 people, we could also see that there were a lot of barriers for different user groups and different user clusters. Some barriers interrelated for different user groups and user clusters, some barriers didn't. And it was very important to prioritize barriers, not only personalize them. We could also see that by not employing methods of tailoring or personalization, users were not accessing the information that they actually needed, depending on what we had mapped the impediments to be. Meaning that personalization and tailoring is absolutely necessary to channel the user into the right direction in order to help them optimize behavioral outcomes and achieve the clinical outcomes that you wanted to achieve. So as we continue to map more users across different health domains, our proximity to predicting clinical outcomes based on behavioral correlations significantly improves, and it continues to improve. By now, we've got over 100,000 users, and we keep on fine-tuning and adjusting what we do and which barriers we speak to as we move further into Young Africa Live. To give you an example, in terms of uncovering correlations between behavioral impediments, socio-demographic information, and clinical outcomes, we map things like HIV or STD related behavior, look at a user and specific things that keep them from adhering to that behavior, then send them the correct interventions, enabling them to have a higher decision-making ability and feel more empowered, and then enable them to really follow the health behavior that they need to follow in order to stop themselves from contracting HIV, for example, or to adhere to a medication schedule. The longer we do this for, and the more we do this for, the more we can pinpoint around one user or a cluster of users without having to ask them what actually bothers them, because they fall into a scheme, and then we can fast track what the risk engine does and what we forward and how we personalize and tailor. We do this over Meta using WhatsApp because it enables us to scale and scale at a very fast pace. It's low data usage. In other words, it's financially very viable for the markets that we speak to. And as Meta evolves, we can also evolve. And by now we're looking at chatbot and large language modeling, personalized tones. And I mean, you know how fast things are moving. It's pretty incredible. So I can't tell you where it's going to end up, but we constantly learning and constantly improving as we go. So there's a lot in this presentation on the theory of change and how we have applied it and how it works. You're welcome to look at that after the presentation. And I'm looking forward to your questions. Thank you for listening.
Thank you, Anne. That was fantastic. Just one sort of quick clarification. The survey that you mentioned, is that a face-to-face or it done via WhatsApp?
In part face-to-face and in part via WhatsApp. Part of the data that we work with also comes from Facebook, because the Young Africa Live was built in conjunction with a Facebook platform that was running. So yeah, different data sources.
Wonderful, very exciting, very exciting.
But that's just, don't get too excited, because it was just the beginning of things. Like, we're waiting on the end line of like a whole, a research paradigm that's much improved from the baseline that we had. And obviously it's not like a small sample like 300. So I can't wait for those results in February.
Oh, that's exciting. It's just around the corner. So we look forward to an updated webinar number 7 to hear those results. So I'm just checking the chat for some questions. Lucky has asked a question of the prior of Cristianne, so I'll come to that in a second. But I'm just noting, she says, I like the way you link the importance of recognizing cultural barriers in improving health behaviors. I don't know if there are any other clarifications folks have for Anne or any of our other speakers. Please just go ahead and put them in the chat or raise your hand and we're happy to let you speak. I'm just cognizant we have our 2 panelists. So let me just invite Lisa Adams and Nicholas Niwagaba. Lisa is the Director of Technology at Girl Effect, spearheading the development of transformative technology products for girls globally, with a special focus on digital health tools, sexual reproductive health, including the award-winning AI chatbots developed for the Global South. She's also the founder of Citizen Code, an African technology agency dedicated to creating impactful solutions by African women for Africa. She is joined by Nicholas, who's a public health specialist and human rights advocate. He serves as the country director for Uganda with Trigger Eyes, a global nonprofit organization that uses innovative technology, real-time data, and behavioral insights to inspire youth to make the best health decisions. Nicholas passionately advocates for youth leadership, social accountability, gender equality, equity, universal healthcare coverage, and health system strengthening. Can I invite both of our panelists to make a comment on the presentations? Can be to one of the three speakers. And if you could enable your cameras, I'd really appreciate it. Can we start with you, Lisa?
Hi, yes, thank you. I think what stands out to me a lot just listening to everybody's work is the golden thread of being user-centric and user-focused. So I think that, you know, in even the work that I'm involved with at Girl Effect, we're obviously focused on adolescent healthcare as well. And I'm in just full agreement of having the approach of human-centered design practices and approaching our work just generally as our end users are our experts, and they should be telling us what they need, what it should look like, what it should sound like. And it's just really exciting for me, as just my first comment, to see that we're all on the same page. I think all of our theories of change are aligning, and I hope one day we can have some global combined theory of change where we can start to just share more of our work and research and combining that as one practice more globally. So that's my first observations.
Great. Thank you so much. Nicholas, do you have any observations or comments for our speakers?
Yeah, thank you so much, and thank you so much, Kat and Kistenmacher, for those wonderful presentations. I think I agree with my panelists. We are quite aligned and similar in terms of how we are thinking about digital tools and digital platforms. As you have mentioned, at Trigger Eyes, we do implement a digital platform across 6 countries in sub-Saharan Africa. And what our platform does is really to motivate young people to make positive choices, and it does connect demand to supply and linking young people to care, just like all the other platforms that we've seen today. There are a couple of things that came out quite strongly, and I just wanted to supplement on the presentation about 3. I'll be very quick. One is around engagement, and I think what has worked on our side is the nudges. So we do encourage rating on our platform, and those and we provide nudges for whoever rates. So they're non-financial rewards that they will get, but we've seen that almost 90% of young people or end users actually rate for the point of it. We are in for the win, right? That specific nudges actually do motivate them to keep them engaged. I love the bit about Christine that she mentioned around everything is connected. I think it's one thing that is quite very important. So making sure that there is integration, right? So on our platform, our end users don't have to download an application, and most of them in our client exit interviews mentioned that that is what they found very fascinating. So there's a whole application bias and where people are really tired. So allowing them to interact with social media platforms that they already use, whether it's Telegram, WhatsApp, TikTok, I think it's something that works very well to ensure that they're engaged and they're not required to have a certain other app that they will not use at the end of the day. Real-time support is quite very important. I think the troubleshooting, young people are always up late in the night interacting with our platform. Are you able to ensure that they do get the answers that they need in case there is any challenge? And maybe lastly, the bit of no data and making sure that there's we do provide for both offline and online interaction. I think it's quite very important. Our platform targets the most vulnerable young people. These don't have the ability to buy airtime or data or even on a smartphone. So making sure that we are And especially for HIV now, we're saying the last mile, we don't leave anyone behind. So making sure that you are thinking comprehensively about your target audience is very important. We did a small pilot in Uganda where I think we provided high-tech solution. You have a smartphone, then we had no tech at all that requires you to have a card, a voucher card that you can interact with our platform. And then we had low tech, which is a feature phone that doesn't require internet. And what we saw across all these 3 tech pathways, 75% were interacting with our platform using SMS with a feature phone. So most of them did not afford airtime, did not afford data or didn't afford a smartphone, but SMS was the best way to interact with our platform. And it was surprising. What was fascinating about this data, it was only 5% that had a smartphone or were interacting with WhatsApp and Twitter, and that told us quite a lot. And a huge number, about 20%, used voucher cards, so they didn't have a phone at all. And this program was targeting adolescents 15 to 19-year-olds. So I think having both options is quite very important depending on your target audience. So that's really it that I wanted to share, but I'm really learning as well on this course, I think.
Great. No, thank you so much for that thoughtful comment. I wonder, Anne, I'm going to turn it to you in a second because I realize we've left you off on some of the questions, so I'll come to you first. But Nicholas, just some wonderful thoughts there that I thought I'll just sort of pull on those threads a little bit more. In particular, kind of this issue of considering sort of potentially the diverse needs of different respondent populations. So I noticed many of our speakers in talking about engagement talked about the need to acknowledge the varied subpopulations. So I wonder, Anne, if you think about human-centered design, can you sort of reflect a little bit on how you design for the varied needs of your sort of of your populations?
Yeah, sure. I think without having stated,
yeah, go ahead. Sorry.
Without having stated it, obviously our first and foremost thought was heightening user engagement. Without user engagement, there's no success. I mean, and we knew that if can you hear me?
Yeah, go ahead. Yeah.
Okay. And we knew that if we didn't personalize the content or the interventions on the apps, our chances would lessen and lessen and lessen. So we spent or invested a lot of time in researching different parameters, and the beginning was onboarding factors, which you can just map, like in terms of where does a person stay, how much income do they have, what culture, religion, whatever you wanted to ask pertaining to that particular health domain. There are many indicators that you will pick up in existing literature that tell you about risk of losing someone in terms of engagement on particular topics based on particular things that you can map, and also specifically to maintaining healthy behaviors. There's a lot of correlation to the maintenance of healthy behaviors and income, for example, or your patient-provider relationship, or different things that you can ask. So that was our outset. Now, we worked with that in terms of like establishing cumulative risk. So if a user had a couple of data points that would accumulate a risk, it would prioritize the user as being high risk, in which case the user had a different pathway that they were sent on, and different priorities had to be met. Amongst other things, an assumption that we had was that if you are not on top of the world mentally, and you suffer from something like high anxiety or depression, that the likelihood that you would engage with a platform or a chatbot or an app it's just zero. It's like you will not be able to engage properly, and you will not be able to maintain an engagement. So depending on how high a behavioral risk factor would be within a particular health domain mapped to a particular risk of a user, we started experimenting and investigating on if we prioritize different topics, depending on what we mapped, together with the cumulative risk score that we had per user, would we be able to prolong engagement, or would the engagement be different, or would we look like, could we get a user to hop from one health domain onto a different health domain on account of what we were mapping in that behavioral pattern? And then obviously mapping it all the way to the end, and that was mainly observational or based on user interviews, because obviously we wouldn't have clinical outcomes on condom usage and things like that. So it would be user-based. And then backtracked as to, did we choose the right intervention at the right time? Was a heightened or a better clinical outcome the result of the behavioral intervention, which improved the score, the behavioral score from before and after? I'm getting muddled. It sounds really complicated, but at the end of the day, it's a simple correlation between onboarding risk factors, behavioral persistence, in particular behavioral categories such as mental health and resilience and connectedness and very specific barriers that we chose, and then clinical outcomes. And machine learning is such a nifty thing nowadays. I mean, it has been for a long, long time, but it's becoming more and more available. And that's what made our thinking possible and our work. Did I answer your question?
Great. Yes, very well. Very fascinating. I have questions, but I've just noticed there's a question in the chat. So it says, thanks for the great talks. What is the age range of adolescent users? And was there any involvement of parent guardians either for consent or to discuss the content? I think that might be directed to Anne, but please do correct me if I'm wrong. Anne, can you take that question, a stab at that question, if you don't mind?
Young Africa Live aims, it's a user group from 15 to 25. Okay. The surveys and everything that we did openly was consent, like age without having your parents' consent. If you were underage, you would have to have your parents' consent, and that was part of opting into the chatbot. Great.
And I just wonder, just building off of that, and how do you handle consent of system-generated data use? Is that something that we need to think about broadly in terms of measuring engagement? Do we need to consent users at the beginning? Okay, over. Sorry.
Consent. Is that me? Sorry. Or is it someone else answering this?
You can, and then I'll pass it to our other speakers as well. Go ahead, Anne.
Okay. It's a big thing for us. And I think within healthcare, I mean, any data collection app platform has to consider that. And consent is one of the things it's one of the first things that you have to look out for, especially when gathering data. Even though it's gathered on an anonymous base, the user still has to know what's happening, what they're in for, where the data goes, and who's handling it, how it's being kept. I'm not an engineer. I can't tell you the technical details. I just know that that's one of the first things that we are confronted with.
Great. And I just wonder, Cristianne, I wonder if you could just sort of comment on what you think some of the key drivers of engagement are for your services. And I know you spoke quite a lot about monitoring the differential rates of use. And I know, given your sort of focus on human-centered design and ensuring sort of high levels of user engagement, I wondered if you had any advice you could offer for our audience. Over.
Sure. And I think one piece of advice connected to what Anne was just saying as well is I do think it's important as well is that there should be a level of anonymity to certain elements. Young people don't want to feel that everything is being tracked either. So I think it is important to be honest and transparent upfront about what is tracked and what isn't. And if it says that it's anonymous, it really needs to be able to be maintained anonymously and to be looked at an aggregate level. So if you're disaggregating down to a client level, that definitely needs, to be disclosed. But I think that's something that we've really feedback that we've had from users is that idea that you weren't going to judge me and that I could anonymously look, like that's a key driver for young people, both in services, but also in virtual services. There's definitely an awareness that they're tracked. And so that idea that, I have a space where I can be fully anonymous, I do think is important. I also think it's really important is giving young people options. So we can talk digital tools all day, but it doesn't replace humans either. And what's comfortable for one person isn't for another. And so I think in anything that we create, it's really important that it's always able to connect in and give a young person options of what they want to connect in with when. And I might be comfortable to say one thing in front of a human, but then I'm not maybe comfortable asking you about the risk of anal sex compared to vaginal sex, for instance. But if you open up the platform, we've had a good conversation when I'm with you in person, and then you say, hey, this is another place you can go for information, we increase the likelihood that that young person's going to go and find out that information. So I think options is a big part of design approach.
That's great. Kate, I wonder, just sort of bringing you back, you mentioned your work is focused on many countries in Africa, bringing up some of the themes that Nicholas was talking about. I wonder if you could sort of, here in South Africa, we are unique in that there's near gender parity and access to mobile technology. However, that's not the story, as Nicholas sort of rightly raised, in many other settings, and you have lots of issues with phone sharing, a lot of barriers around, sort of accessing data, accessing higher quality phones, particularly for women. I wonder if you could reflect on how you handle and seek to bolster engagement among these varied populations. Over.
Yeah, I think both the points that Nicholas and Cristianne raised are really at the center of that. So trying to think across different levels of tech availability and comfort, and then really ensuring that we're not limiting ourselves to tech only or human only solutions, so that there is always an option, because even someone who has a smartphone one week may not have it the next week. So thinking about kind of the continuity of communication. So one of the pieces that we've been trying to, I think, work through a lot recently is how do you taking a lead from Anne, really, how do you identify the core components, and how does that translate from, a data-rich environment, a feature-rich environment that you might have on a smartphone? How does that translate to perhaps a WhatsApp-only focus, and how does that translate to an SMS-only focus? And there are still fundamental engagement practices that can translate across those different platforms, and it might look different, but really using behavior change theory and keeping those end users at the center and involved in what is engaging across those different platforms, I think is one piece that we have been focusing a lot on, I think, recently.
No, that's very helpful. Just one last sort of little bit more challenging question. So this issue of scale and scaling up. So I wonder what advice you have for individuals that are thinking of developing new technologies or services, how to optimize the potential for impact, and in turn the case they need to make now in terms of evidence generation, in terms of other sort of maybe policy outreach, to bolster the chances of their solution being scaled and taken up by governments or other key stakeholders. Over.
Yeah, I mean, I think some of the similar pieces are there. If you're at the very start, an important question to ask is whether you do need to build something new, or can you use an existing platform or build on an existing platform, because of that issue around sustainability. These interventions are living objects and evolving, and so the upkeep and maintenance of a standalone or new platform can be quite high. And so if using something, like a WhatsApp or a Facebook, or partnering with an existing group that has a sustained platform, can be a way to both reduce your upfront investment and cost and human resource needs, as well as increase the chances that you might have more sustainability down the road, or ability to expand or implement that. I think the other piece that we haven't talked much about is sort of thinking about open source tools is another place where people can look. It may not be commercially available, but different open source options that are out there would be another space to consider.
Oh, that's great. Cristianne, I wondered if you had any closing thoughts or reflections on today's, on anything that's been asked or raised by our other speakers.
Thank you. I think I just, first of all, like to say thank you for the opportunity. I think that I really echo Kate in that collaboration is so important. I think that we're seeing a lot of reinvention of the wheel. And I think there's definitely a scramble right now, is the kind of like everybody feels I've got to have an app kind of a thing. And we don't necessarily. I think that we can drive a lot of greater functionality if we work together. And if we can share a lot of that. And even when it's not open source, I think to look at where there's mutual benefit. So for implementers who are on the ground, they may not necessarily have that technology, whereas even if they do, maybe they don't have the research capability to look at, the impact and set the research up right. So even if it's not directly in the creation of the digital tool, I think there's still a lot of potential for collaboration, even around the use of the tool. And so I would really like to leave that as kind of the ending remark, is that I think we can really do more together.
Wonderful, thank you. Anne, any closing thoughts or reflections?
I'm fully on board with what has been said. One of the reasons why I started thinking around the platform like I did was exactly because of that. Because how many more apps are we going to build that look after medication adherence? Or how many more are we going to? And every time we do that, we lose more and more funding. And there are so many smart people out there. And the area of expertise is so wide and varied that if for once we manage to sit around one table, we could actually make this work. And I think, if anything, I hope that the framework we're building will form like a baseline to test interventions like that for depression or for HIV or for whatever it might be. And yeah, that would be a dream come true if we started working together more.
Wonderful. Nicholas, can I ask you to come in with any closing thoughts before I hand over to Lisa and then close us out for today?
Yeah, thank you so much. I just felt like Anne said exactly what I wanted to say. But again, I'll just user-centered design, quite very important for us to understand who we are actually designing this platform for. And again, the app fatigue is just out there, and we are getting this feedback. I think the whole beauty of integrating and us as innovators work together for us to be able to find something that works for all. I really want to also appreciate the organizer of this webinar. I think it's the first step towards us actually collaborating more and speaking the same language in the future, and also the research that is currently being done, because it's pointing to areas of improvement which us as program managers need to look out to. So thank you so much. Yeah.
Thank you, Nicholas. That's a wonderful, very thoughtful. Lisa, any closing thoughts?
So difficult. Everybody seems to have covered really all the important parts, and I think I'll just echo the sentiments that I made earlier, which is, I agree. I think we're all trying to achieve the same goal. I think we're all doing research in isolation, and we're building things differently. I think for me, a dream for both Girl Effect and Citizen Code is to have a more of a marketplace approach, where we're putting all our services together in one space and not duplicating things, but really defining what we have with each other and with all our experience. It would be really wonderful to see. And I just want to really give a lot of praise to everybody who is building, and the technologists behind all of this work, for having such a strong focus on really understanding a dignified experience for users, which is not forcing services onto people, but understanding the states of readiness that users need to be in. And it's wonderful. I'm so excited to see even product ecosystems getting broken down, and we're not just trying to build one tool to be the one-stop shop, but having a variety and a diversity of offerings for all the end users. So thank you so much, everyone.
Thank you so much, Lisa. So I'd like to thank all of you for attending today and for your interest and for your thoughtful engagement. I'd particularly like to thank our speakers, the panelists, and our artist, and our colleagues at Desmond Tutu Foundation for bringing us here today, and for all their hard work in organizing this session. A lot goes in behind the scenes to getting us all here, and we wouldn't be here without them. So a big shout out to our colleagues at Desmond Tutu Health Foundation, and thank you to IAVI as well for sponsoring this. So thank you all. Wishing you a wonderful afternoon.
Thank you.
Thank you so much.
Thank you so much.